I welcome everyone. My PhD topic is about the role of endoscopic interventions in the management of pancreatobiliary diseases. I would briefly introduce myself. I am working in the Department of Surgery, Transplantation, Gastroenterology at Semmelweis University. And my supervisor is Dr. István Ritz, and my SMS is Annette Rantz. And my vision with my work is to reduce mortality and morbidity related to pancreatobiliary disorders. And I tend to achieve this via enhancement of the safety and efficacy of these procedures. And to fulfill this goal, I'm currently working on two specific projects. The first is about to understand the role of different endoscopic, different ERCP techniques following Roux-en-Y gastric bypass operations by conducting a systematic review and meta-analysis. And the second is about the improvement of endoscopic management of pancreatic necrosis. Let me start with the first one. So Roux-en-Y gastric bypass. Patients who undergo this type of procedure are prone to develop pancreatobiliary complications mostly due to the rapid weight loss. And according to a survey by Agriassini et al., published in 2021, almost 49,000 Roux-en-Y gastric bypass operations are performed in Europe yearly. And this means that there is a considerable, or at least not negligible, chance that a patient with such a surgically altered anatomy is presented to a gastroenterology ward with the need of biliary intervention. And what is the problem with that? Because if we want to perform this biliary intervention via a retrograde way, that possible endoscopic interventions all require different endoscopic skills, different instruments, which come with different prices as well. And as you can see, the three most common used endoscopic techniques depicted on the slide, the laparoscopy assisted ERCP technique and the EUS assisted technique or seem to be more effective but less safe than the enteroscopy assisted technique, according to literature data, which the enteroscopy assisted technique being probably the most physiological by considering the access route to the papilla. So we aim with our project to fill in knowledge gaps, because this difference or controversy creates quite a dilemma in therapeutic decision making, and we aim to somehow solve this problem with our project. So we were searching for whether there are any differences between these interventions, hypothesizing that there are, favoring edge and the laparoscopy assisted technique. And after the selection process, we identified 67 articles enrolling more than 2,000 patients. And here comes the first result, which depicts the access rate to the papilla, which clearly shows that the endoscopic ultrasound-directed method and laparoscopy-assisted techniques are clearly superior over the enteroscopy-assisted techniques in terms of successfully reaching the papilla. And when we investigate the ERCP success rates, we also find that this difference between the techniques grows even larger, and the difference remaining statistically significant. But if we investigate the overall complication rate, which we could remember that it was supposed that enteroscopy-assisted technique is safer than the other two, then we can say that although it trends to be safer according to our calculations, but this difference did not reach the level of statistical significance. There are several strengths to our study. We implemented very strict inclusion criteria for the population, and also for the statistical calculations. We only calculated with data registered on a per procedure basis, and ensuring thus the statistical independence of data. But of course, most of the studies, or vast majority of the studies, are retrospective in nature, with inherent limitations, and also probably the variation of expertise among endoscopists could have influenced the results of the enrolled studies. But all in all, we can say that I would recommend that our project has clinical and research applications. For clinical applications, I would say that I can only encourage centers to perform more endoscopic ultrasound-directed ERCP interventions in these patients. And for the research implications, it's plain to see that more prospective studies are needed. This is the current stance of the progress. The manuscript is finished, and after a few adjustments, I hope it will be sent for submission in the coming weeks. And my second topic is a plan for a prospective, possibly randomized trial, which would compare two endoscopic treatment options in the management of ward of pancreatic necrosis. Wounds are late local complication of acute necrotizing pancreatitis, which I would just briefly introduce, or at least their management, because if certain criteria are met, they have to be treated, preferably via an endoscopic way. And one of the most accepted treatment options is to place a metal stent into this necrotic cavity via the GI lumen, and then performing a necrosectomy by entering the cavity with an endoscope. And but whether how exactly this should be done, how often, how regular, these are open questions remaining still unanswered, and we aim with our project to find an answer for this by investigating whether an on-demand, necrosectomy performed in an on-demand fashion would be more beneficial for patients than a regularly performed necrosectomy. And as a summary, I said that this planned submission date for the first project is planned for the next month, and I hope that the protocol of the second project can be submitted also by the end of this year. And I would like to finish my talk with a quote from Mark Twain, that be careful about reading health books, as you may die of a misprint. Thank you very much.
What are your explanations about the lower success rate of enteroscopy-assisted ERCPs compared to the other two methods? First question. And the second one, did you perform, or are you planning to perform, any cost effectiveness analysis comparing the two effective methods, the EDGE and the laparoscopy-assisted ERCPs? What do you think, what might be the difference between them?
Thank you for the questions. The first, it probably is associated with the length of the limb, which is created by the surgeon. In most of the cases, if it's longer than 150 centimeters, then it becomes very difficult to access the papilla with an enteroscope through the anastomosis. And this is very often the case in Roux-en-Y gastric bypass procedures. So the most common problem is that the papilla cannot be reached with the enteroscope. And of course, these instruments lack the special capabilities of the duodenoscopes as well. And regarding the second questions, So in our current project, we don't intend to, because I think there are some evidence with quite good quality in the data, in the literature, about cost-effectiveness analysis. I would like to mention here the study performed by James et al., who I think it was published in 2019, who found that echo adjusted to the quality, the quality adjusted as the life years and the expenses of the procedures, and the results showed that EDGE is superior to laparoscopy-assisted technique and enteroscopy-assisted techniques as well. But there are other studies which shows also that laparoscopy is far the most costly procedure technique of all of them. Why the difference between the enteroscopy-assisted technique and EDGE being not significant.
What about patients with nasocystic drainage? Are they going to be included in your population, excluded, or stratified according to nasocystic irrigation?
It remains to be answered. So the use of nasocystic drains are also not a standardized way of the treatment of these patients, but it's often used. It remains to be seen. It remains to be seen in Hungarian centers where necrosectomy is performed, and in Hungarian centers where actually wounds are treated. This nasocystic catheter is usually placed.
I'm just curious, like, how do you go to translate the result of the first project into your practice, clinical practice? And maybe if you can give me a little bit of insight, like how is done nowadays, how the clinician decide which technique will be used. Thank you.
Thank you. So I think the decision nowadays is based on local expertise and on local capabilities and financial considerations, and which is one of the aim of our study, that it should be this decision should also be based on the knowledge on the deeper knowledge and clearer knowledge of the complications and success rates of each procedure. And how does it looks nowadays? Unfortunately, since I am working at the university hospital, I have not met a single patient with biliary indications with Roux-en-Y gastric bypass anatomy. So I cannot tell you, unfortunately, first-hand experience about that.
Bálint, what is your opinion? What is your so-called gut feeling about your second project? Do you think that we will be able to do less procedures for these patients? Can this project prove that a lot of patients may get away with much less procedures, much fewer number of procedures than the kind of the elective way would suggest? Because this is something we usually tend to follow mainly to treat our own anxiety as well, just to make sure that the patient really improves. And, even if the patient has got one less necrosectomy, one less gastroscopy, which is under sedation, comes with some risks and a lot of discomfort on the patient's part. That is a huge gain from the patient point of view, and also from the managing of your endoscopy unit, because that blocks your endoscopy unit if you do a long necrosectomy and if it's unnecessary. So what do you think? Do we need to do less or more? Fewer or more?
I can base my answer for from one side on the previous data, which some of them favor, some of them are less favorable for the regular interventions. And there is a pilot study which was performed by our research group or our endoscopy unit a few years ago, which proved the beneficial effect of performing regular interventions or planned interventions.